Hello, my name is John Frater, and it's very nice to be able to give this lecture to you today on SARS-CoV-2 immunity in people who have HIV and also in other immunosuppressed individuals. And in particular, we're going to be looking at immune responses to infection and also to vaccination. I have nothing to disclose. So what we're going to cover is mostly around people with HIV. I'll touch a little bit on COVID disease in people with HIV, but this has been covered really well elsewhere. But what I want to focus on is immune responses following infection and how that might impact kind of immune responses following vaccination. And then at the end, we'll touch a little bit on other immune suppressed states, which I think are going to be increasingly important as the pandemic kind of rolls forward. So let's start with HIV and COVID itself. So this is the premise we're working from, is that historically we know that for many people, not all, but many people with HIV may well respond less well to vaccination. But up until recently, there's been very little data on COVID vaccination in this population. Historically, I think HIV, we can say, has resulted in poorer vaccine responses in some scenarios compared to people who don't have HIV. We've seen this with influenza vaccination and an example of with hepatitis B having to need to give an extra booster dose occasionally to get those sort of levels that you need for protection. And also that scenario where you might have a lower CD4 T cell count, where you might be nervous about giving a live vaccine in that case. The bottom bullet point there is really important, that antiretroviral therapy really has changed the landscape in terms of the impact of good CD4 T cell restoration and how that impacts vaccination. But one might argue that things aren't quite perfect yet. And that's kind of what we want to explore in this lecture. I'm going to start off talking just a bit of overview about what we know about HIV and COVID itself. And just historically, I think it's probably fair to say that as this all started off, many of us working in the clinic felt that people with HIV weren't particularly at increased risk of infection or clinical progression if they had HIV, and certainly that was the message we were giving in our clinics. And then evidence sort of picked up from Spain, from Africa, also from the UK, saying, well, look, maybe that isn't the case. Maybe there is increased risk of infection in some people with HIV, and if they were to have HIV, maybe there's increased risk of progression, disease progression, and potentially mortality. And on the back of that, there was a lot of advocacy, as you can see on the slide there, from AMFAR and other groups, saying that people living with HIV should be prioritized for coronavirus vaccination, which then becomes really important to understand if a vaccine is going to have the same immunological response as someone with HIV. But it does a bit of data to say kind of where we were basing this sort of premise on. This is a paper from Lancet HIV earlier in 2021. And you can see on the left there, that sort of blue shaded area of people with HIV and cumulative mortality. And it's really quite a striking figure, that saying that if you have HIV, and you're admitted to hospital, you are more likely not to survive compared with someone who doesn't HIV. And then you look on the right and you look at the various sort of things that are feeding into that result. You can certainly see that people of Black ethnicity and other people with comorbidity that contributed very much to that statistic. But this is a really tricky area to be in. And Caroline Sabin has given a really nice lecture going into the details of this and talking about kind of the different confounding factors that make sense of this, because not all studies agree. And there may be the issues around comorbidities of people with HIV. When you take antiretroviral therapy into consideration, does that change this sort of dynamic? So it's certainly not a clear area, but I think there's probably a feeling that there is probably a slight increased risk, which we need to take consideration of. But I don't really want to talk about that anymore. What I really want to focus on for this short lecture is about immune responses. Firstly, in people with HIV infected with SARS-CoV-2, and then following that, really focusing on vaccination. So the first question then is, if you have HIV and you catch COVID, what sort of immune responses do you make, and how do they compare with people who don't have HIV? And there's a nice paper out earlier in this. It's a preprint at the moment, as far as I can see. Dimitri Pepper's team have published this, and it's a really nice example of a number of people with HIV infected with SARS-CoV-2 and how their immune responses compare with people without HIV. On the left, I'm sorry it's a little bit blurry, but on the left, what you can see there is the spike immunoglobulin titers here in people without HIV and in people with HIV. And then here is the N protein responses showing that this is infection rather than vaccination. And the first thing to take from the serology there is that people with HIV and people without HIV are making very similar immune responses. When you look at the T cells, and I think it's really important not to forget the T cells, because I suspect they are really actually critical to protection, maybe more than we realize, is that, again, if you look at the hierarchy of T cell responses, and this is a very nice figure that shows the SARS-CoV-2 virus broken down by protein and where the immune response is being focused in different individuals in the hierarchy. And the key thing to take from this figure is if you look at people without HIV and people with HIV, actually they almost overlap in terms of where that sort of immunodominant responses are taking place. So it looks very much like T cell responses are very similar, and serology, IgG, and other responses are very similar, regardless of whether you have HIV or not, and you are challenged by an infection with the virus. So that's a really nice starting point to move from. And then the question then is kind of how does that impact on vaccination? One of the interesting things that came out of this paper is that the magnitude of T cell responses in people with HIV was impacted by the naive CD4 T cell count, which isn't that surprising, but also interestingly, the CD4-CD8 ratio, this ratio that keeps coming up in different scenarios as a sort of marker of prognosis and outcome. And here again, we see the CD4-CD8 ratio being a marker of whether you make a good T cell response or not. And I think that's, a really useful ratio to have and bear in mind. But let's move on to what happens with vaccination. So someone with HIV, if they are vaccinated, what sort of immune responses are we going to see? And the way we approached this was a sub-study of something called COV-002. You may be familiar with this. COV-002 is the enormous phase 2/3 study that's been rolled out of Oxford in conjunction with AstraZeneca to get efficacy data on the AstraZeneca Oxford vaccine, here called ChAdOx1 and COV-19. And this is a chimp adenovirus, which many of you will be familiar with, widely distributed around the world now as part of the global vaccine campaign. And COV-002 was one of the key studies in different populations looking for efficacy and immune responses and safety in this virus. We had a sub-study of that where we specifically looked at people who were living with HIV. This is what that study looks like. It was HIV positive adults over the age of 18. They all had to be on antiretroviral therapy with undetectable viral loads, and they all had to have CD4 counts greater than 350. So this is a very specific subgroup. We're looking at people who are doing well on therapy with good immune reconstitution. Lots of discussions around, what other groups we're interested in, and, particularly people with lower CD4 counts are going to be interesting. But what we wanted to say in the first instance is if you take people who are doing really well on therapy with good CD4 counts and they get a vaccine, what sort of immune responses are we going to see? We recruited this cohort in two sites in London at St Mary's Hospital and Guy's Hospital with my colleagues Sarah Fiddler and Julie Fox. They had the standard dosing, 4 to 6 weeks apart. Most of them were 4 weeks apart according to protocol. And we aimed for 60 individuals in total, and in the end, we recruited 54 people. This is what study design looks like. Fairly straightforward. So at day 0, you had your ChAdOx1 and COV-19 prime. 4 weeks later, you have your boost. In green, we have the sampling time points. So day 0, 14, 28, 42, and day 56. A large volume of blood was taken at each of those for serology and T cell work, and I'll be presenting the day 56 data today. The 6-month data has now been collected and is being analysed as we speak, and we will be bringing the participants back for their 12-month study in a few months' time. So we will have a full 1 year's worth of T cell data on these. What are the endpoints? Well, predominantly safety and reactogenicity. So primarily, above all things, we need to make sure this vaccine is safe, and we want to have a look at the sort of responses people are making in terms of sort of side effects when they get that vaccine. But once we can get that ruled out and acknowledged to be safe, then really the interest there is in terms of antibodies and cell-mediated responses. And for the antibody responses, it's predominantly seroconversion using ELISAs against the spike protein, and then other assays are used, such as neutralization assays and others, to try and confirm and shore those up. Cell-mediated responses, again, something of key interest to us. We use a T-cell ELISpot looking at gamma interferon responses, again, to the spike protein, but then look at other potentially different ways of measuring T-cell responses, such as proliferation, other responses like that. So getting a whole panel of assays together to seeing how they talk to each other and how they sort of measure what an immune response to a vaccine might look like. So what did we find? So first of all, this is just an example of the 54 individuals. This is what their CD4 T cell counts look like, and that gives you a feel for what this population was. So as you can see, really recruiting all above 350 upwards, but a really nice, strong display of CD4 T cell count. So that might put you in a position to say, well, look, this looks very reassuring. We would hope and expect to see some really nice vaccine responses from these individuals. But just to remind us why we do this study and why we are interested in people with HIV is this is the activation, the immune activation data from the same participants that we vaccinated at day 0, day 42, and then in 6 months. So I'll just go back there at 6 months. And what you can see in orange there is these are the people with HIV. Their immune activation on CD8 T cells measured by CD38 and HLA-DR co-expression. And even though they've been on therapy for a long time, even though viral loads are undetectable and their CD4 counts are high, you can see that at all time points, compared to our HIV negative control group, there is a significantly raised immune activation in this population. So we know that kind of things have not normalized in terms of sort of the platform from which the immune response is working from. And that might be the premise why we might be concerned that even though your CD4 count might be fantastic, you may not, for some reason, have an equivalent immune response to vaccination. So that's why we were interested. What did we actually find? So first of all, in terms of reactogenicity, these are the sort of things we were looking for. You can see across the top: chills, fatigue, feverishness, headache, joint pain, malaise, muscle ache, nausea, classic responses to vaccination. And in the red box, I've got the people with HIV after their prime, and you can see the number of people reporting these symptoms days after vaccination. And then if we look down at the HIV negative control group, you can see it's very similar numbers. If anything, the people with HIV have slightly fewer symptoms, but very much mapping what we're seeing after the prime dose in the HIV positive and the HIV negative group. And then if we look down at the booster doses here, people with HIV boxed there, and then in comparison with the HIV negative people and the boxes that just come up there, we can see, again, slightly fewer side effects after the boosters, which have been reported elsewhere following the AstraZeneca boost vaccination. And we can see, again, really similar mapping between those with HIV and those without HIV. Again, very reassuring data in terms of safety, and that there isn't any difference of note between people with HIV and people who don't have HIV. What about antibody responses then? So this is the first data I'm going to show you on IgG responses to spike as a whole, not broken down any further than that. And what you can see over time, over the first 56 days following vaccination, this is day 0 for the prime, day 28 for the boost, we can simply get a nice rise after day 14, and then this continues upwards. Following the boost, we go up to day 42, and then with a plateau around day 56. But we get a significant difference compared to baseline, really nice responses. Interestingly, there are a few people making baseline responses that are raised, and they didn't have previous infection with SARS-CoV-2, so there's interesting debates about what is that cross-reactivity to, which is probably for another lecture, but that is very interesting. And then if we take that serology and say, well, how does that sort of map into the functional behavior of those antibodies? Here is a focus reduction neutralization assay, which represents viral neutralization. And as you can see over time, out to day 56, we go from a 0 baseline. And we see that the vast majority of patients are making nice neutralizing responses by day 56 post-prime. And that's statistically significant. So we can be reassured there that people with HIV are making nice vaccine responses. The question then is, how does that compare to people without HIV? And I think this is a really pleasing figure to be able to present, because what this shows, and as we published recently in Lancet HIV, is that actually people with HIV and people without HIV, their responses pretty much overlap each other. So for our people in clinic who are looking after with HIV, we can give them that message that if they have a vaccine, the responses that they make, if their CD4 counts are good, are going to be very similar to if they didn't have HIV. So that's fantastic news. And then the T cells. So we know the serology looks good. What happens with the T cell responses? So this is gamma interferon elistot against spike. And you can see here how this assay was carried out, 12 pools of overlapping peptides, detailed there, all done in triplicate. And as you can see here, baseline, we have day 0, and then following that prime, you get a really nice response, boost here, and then plateaus. And we see this with the T cell response in AstraZeneca. You don't get that same sort of post-boost elevation in the T cell responses, but they do remain elevated and they do remain protective. And if you look across on the right-hand side here, when we compare with HIV negative adults, we get the same picture. So we see very similar responses compared to people who don't have HIV. And again, really reassuring data that the serology and the T cells are agreeing with each other, saying that people who don't have HIV, people who do have HIV make very similar immune responses following this vaccination. So that's really encouraging. Another assay we can use is T cell proliferation, which is a really exciting assay because it gives much more sort of in-depth and a kind of granular view of how a T cell response potentially functioning to antigen stimulation. This is when the T cells are stimulated and let to proliferate for 5 days. And if you look here, dividing spike up into spike 1 and spike 2, basically dividing in half. Again, similar sort of thing. This is where you get your prime. Day 28 boost, we see a nice rise over time of T cell proliferation, showing so that those ELISpot responses I showed you earlier really map also into proliferation and other ways of measuring T cell responses. So again, lots of reasons to think that people with HIV are going to respond really nicely to vaccination. But I would just say, I presented data on people on therapy doing well. And just as that caveat that I think you probably don't need to be reminded of, that you need to be careful if we're going to apply this across everybody. And this is an N=1 case from Dimitri Pepper's group, again published in Lancet HIV this year. N=1, but this is someone who wasn't on therapy when they were first vaccinated. High viral load, you can see 800,000, CD4 count of 20. They did start therapy and get an undetectable viral load during their vaccination program and raise their CD4 counts up to 70. But despite all of that, they didn't make any antibody response or ELISpot response or neutralization response by vaccination. So it's only N=1, but it is just to reinforce that point that your CD4 count is likely to be critical. And that although most people on therapy are going to do well with vaccination, we just need to be aware that there may be some issues in those who are not so well protected. Okay, we've talked about HIV. I've only got a few minutes left, and I just want to cover other health conditions that are going to be relevant in terms of our vaccination program against SARS-CoV-2. And this kind of broadens out beyond infectious diseases now. People with organ transplants, stem cell transplants in particular for hematological malignancies, blood cancers, solid cancers, advanced kidney and liver disease, we know impacts your immune function. And again, those who may be receiving immunosuppressive drugs for other conditions. And I think this is going to be a really important group as we move forward, because as the vaccination program rolls out and people get protected, we are potentially going to be leaving some people behind who aren't protected, and we need to make sure we know what to do with those. Now, in order to kind of get heads around all of that, we need to have a proper and great study. And there's a really nice study in the UK, for example, called Octave, being run out of a number of different universities, colleagues, Celia Dunnicky and Ellie Barnes in Oxford, leading from our point of view here. And the idea is to build up a really large cohort of individuals who may be immunosuppressed and see how they respond to vaccination and also to potentially infection. So just to give you an example of the sort of data, this is people, well, I'll explain what these mean in a second. I'll jump forward for a second just to show you this. So HD is hemodialysis, IBD, inflammatory bowel disease, liver is hepatological disease, AA, Vicky, ANCO-associated vasculitis, inflammatory arthritis, and then healthy controlled. If I just jump back, what you can see first of all is that following vaccination, we have this sort of low responder and non-responder line here. So depending on your condition, you may well make some nice responses. So these are our healthy controls. This is people on hemodialysis, but there are some conditions where you're certainly not seeing nice responses to vaccination. And there is certainly concern there that despite having a prime and a boost of vaccination, these individuals did not make a good response. How are we going to be looking after these as we move forward? If we just look in a bit more detail at this crowd, some of these people, because of the timing of the pandemic, had become infected. And if we look at the people in red who are M positive and so are likely to have had COVID in the past, what you can see is that compared to people who haven't, in grey, been previously infected, vaccine responses are greater if you previously had COVID in this group. So the reason to mention that is if you're concerned about the fact that people might not be responding well to vaccine, and what is your strategy going to be? If there is data suggesting that in people who previously had COVID infection and therefore been antigen exposed, they make a better vaccine response, that might be an argument that one of the strategies you might want to use. So what are we going to do as we move forward in this group? So I think there are probably two ways forward. One is around boosters. And this kind of builds on sort of knowledge from other conditions. And certainly before COVID, for example, in HIV with hepatitis B, we would often give an extra boost to try and get protective levels up to where they should be. And using a booster for COVID is clearly very topical at the moment, and it's about to be rolled out in the UK. We need to be sure it's safe, and there's a study called POV Boost taking place that will give us data on that. But there's already some early data out there suggesting that in some people who don't have antibodies, if you give them a boost, then that might actually just bring them up to a protective level. But we know that in some people that still won't help. And in that scenario, then a booster is not going to be useful. We need a different solution. And this is where neutralizing antibodies are going to be a really exciting way forward. There's lots of neutralizing antibodies coming on the scene now against SARS-CoV-2. One example is a SABRE clinical trial, which we will be starting at Q4 of this year. And this is 2 antibodies developed by Michelle Listenzweig at Rockefeller, LS variants. So they last for around potentially 6 months following injection. They've been picked up by BMS, and we will be using these antibodies to protect people with hematological malignancies and long-term bone marrow suppression or immunosuppression by giving them doses of these antibodies following evidence that their vaccine hasn't worked. So it'll be really exciting to see whether these vaccines, these antibodies give protection in the long term. So that's the other strategy. So I think just to sum up there, I think I've come to the end of my time. I think we can say with confidence that people with HIV will respond really well to vaccination, and that's a really important message for our clinics. But given the caveat about CD4 T cell counts, I think we have data that's short term. The 6-month and 1-year data will be really important to make sure that it's consistent over time and the responses are maintained. And we'll also argue about whether you need a booster. I've mentioned other immunosuppressed groups, and I think this is going to be really key moving forward over the next few years to make sure these people are protected and that we come up with a good strategy in order to protect them. And I think this is going to be a problem for some time. And then the very last slide is just to thank the many people who contributed data and worked so hard in this area. I think there are so many countries focusing on really hard on this, but just to focus on our own groups in Oxford here, my team at the Medwar, Matt Pace and Albay in particular, the Oxford Vaccine team, Andy Pollard, Katie Uetersen and Sarah Gilbert, and my colleagues Sarah Fiddler and Julie Fox, and above all the participants who regularly come back to these studies. So thank you very much.